I think it's an honor to present to you the teacher of teachers, Padam Shri Dr. G. Vijayaraghavan. In ancient mythology, we used to have a fountain of knowledge, and he probably, that fountain personified. He had been a teacher of a postgraduate medical college for more than 50 years. I think to begin, he was the first person to start a 2D echo lab in India. So I don't mind equating him with Feigenbaum and Dr. Naveen C. Nanda. And he is still a emeritus advisor of Royal College of Edinburgh. And he's published his first book on a Doppler echocardiography. That was in the US way back in 1985. And he still has delivered countless lectures. That's what he told me. And he's lost count after 1,000. Dr. Vijayaraghavan, please.
Thank you, Dr. Singh, for the nice words. I love cardiology, and that's where all these lectures come. You may be surprised at the title, Inflammatory Disease of the Pericardium. I will share some of my experiences with inflammatory disease of the pericardium with you so that you can understand the extent to which this can go on. My slide is not moving. 1 second. Okay. Yeah. A 41-year-old housewife, married with 2 children, no non-cardiac comorbidity, patient with rheumatoid arthritis and methotrexate, 2.5 milligram once a week. She had fever for 5 days, subsided on treatment with antibiotics. An episode of syncope after prolonged standing 2 days back, increased exertional dyspnea and orthopnea. I remember to have seen this lady on a Sunday morning. I go to the hospital every Sunday, and she had vague just discomfort and dyspnea. Examination tachycardia, but pulsus paradox is very characteristic. 80/60 blood pressure, JVP raised, mild pedal edema, bilateral basal crepitations, soft tender hepatomegaly. Look at the chest X-ray. Nothing very striking there. Nothing very striking to comment on in the chest X-ray. But when you look at the echocardiogram, you find there is reason for the chest discomfort. There is reason for the discomfort or in respiration. And please look at the pericardium. Never get lost in the pericardial fluid. Please look at the pericardium surrounding the heart. It is thickened, it's angry, it's looking at you. It is very much thickened and boggy. That's the pericardium that has created all this havoc. And the effusion, even though it looks small, it did produce some pressure effects. What pressure effects was it? Look at the RV outflow tract. This is the RV outflow tract. And you can see the RV outflow tract is collapsing. And when is it collapsing? It is collapsing in diastole. Normally, RV outflow tract contracts in systole. It doesn't collapse in diastole. It contracts towards RV outflow tract, contracts in systole, not in diastole. In diastole, if it has to contract, the intrapericardial pressure has to be very high. And we could confirm the pulsus paradox. The right ventricular pressure is the lowest at the beginning of diastole. When the high intrapericardial pressure can indent it. This may not happen if there is RVH or RV3 or infiltrative disease. This sign is less sensitive, 60-90%, but more specific, 80 to 100%, than this patient has RA collapse also. And the RV diastolic collapse occurs in early diastole, immediately after the cross the pulmonary valve, at the time of opening of the tricuspid. When collapse extends from outflow tract to the body of the right ventricle, evidence that intrapericardial pressure is elevated more substantial. We thought of putting in a needle that been decided against, got the rheumatologist, started on high dose of steroids and methotrexate. Dexamethasone 8 milligram OD for 3 days. Deaths are 36 milligram once a day. Methotrexate increased to 10 milligram once a week. And look at it. On the 4th hospital day, the anger of the pericardium is gone. And there's only very little fluid. Not only that, the RV outflow tract contracts insistently, and this movement we saw earlier in diastole. RV outflow tract contracts insistently, and that's a normal phenomenon. The normal phenomenon. Remarkable development within 4 days of medical treatment. 4 days of medical treatment. This was how the RV outflow tract contracted earlier, and this is how the RV outflow tract contracted on the 4th day. Remarkable change. And 2 weeks treatment on steroids and methotrexate, everything has disappeared. Pericardium looked near normal. She was totally asymptomatic. She was totally asymptomatic in 2 weeks' time. What does this teach you? Pericardium is as much alive as any other tissue in the human body. It reacts to different diseases in many ways. Identifying the characteristic signs will help us to correctly diagnose the etiology. Never be carried away by the pericardial effusion. It's only one of the many changes of pericardial pathology. Pericardium, as you know, has a thick parietal layer and a very filmy visceral layer, thick fibrous parietal layer and a filmy membranous visceral layer, and may contain normally 20 to 50 ml of pericardial fluid. And you should always remember that if the aorta is inside the fluid, it is pleural effusion. If aorta is outside the fluid, as you see here, it is pericardial effusion. Pericardial effusion, separation of visceral and parietal pericardium. And here, it is separated. Look at here. This is what you will find in patients when you do echo in acute pericarditis, myopericarditis in patients with viral fevers. But when the separation is significant, you find pericardial fluid accumulates with a lot of fluid between the visceral and parietal layers of the pericardium. It's often silent, small effusion, pericardial rough may be present, and echocardiographic diagnosis is of paramount importance. And as I said, always look at the pericardial pathology and look at the fluid, what's the type of fluid, and identify whether it's an exudate or a transudate. Is the pericardial pathology abnormal or the pericardium normal? Pericardial effusion of mild degree, less than 1 centimeter, is about 100 ml. Moderate degree, at about 1 to 2 centimeters, means under 500 ml, and large is more than 2 centimeters, 500 ml. This is how you roughly estimate the amount of fluid. Here you find the heart swinging within the pericardial fluid, Pericarditis can be acute, non-specific. Pericarditis, especially myopericarditis, you may find in many of the viral fevers, dengue, chikungunya, many of them. And there, the only thing that you may find will be a separation of the pericardium. But if there is more myocarditis, you will find dilatation of the ventricle and reduced ejection fraction. Myopericarditis is what you see here. You have to have a good history, take the good physical findings, serious examination, ECG X-ray, and an echocardiography. Acute viral pericarditis can become massive. Look at this patient with acute viral pericarditis. These are the patients in whom you need for the casualty itself, ER itself, you have to diagnose tamponade and think of aspirating there itself to reduce the hemodynamic embarrassment on the individual. And pericardial pathology, as I said, has to be identified by looking at the pericardium. Look at the pericardium. It is not only thick, it's boggy, and there is regional thickening also seen. These are the kinds of pericardial pathology you find in many diseases, and are characteristic of some of the diseases. Acutely edematous pericardium, amorphous material in the pericardial fluid, indicating high fibrin and proteins, large pericardial effusion. All those things are important. And swinging heart, systolic collapse of the right atrium. You can see the extreme systolic collapse of the right atrium, with a swinging heart, and these are the patients who whom require early urgent pericardiocentesis. Second, edematous pericardium and amorphous material in the pericardial cavity are characteristic of some of the diseases, especially chronic diseases, subacute diseases, where you find a lot of tissue has been denuded and it occupies a pericardial space which could be seen as amorphous material. Acute myocarditis, presentation of myocarditis, febrile illness, tachycardia, tachypnea, hypotension, often with involvement of lungs, rapid progression of symptoms, and hemodynamic deterioration. And this is what you find in such a situation. Look at acute rheumatic fever. The presence of mitral pathology, which are moving. Presence of mitral pathology should always tell you, here is a patient with pre-existing rheumatic heart disease. And this is a patient who has gone in for a pericardial effusion, and all the tests for rheumatic fever will be positive. And please note that in acute rheumatic fever, pericardium is also thick and boggy. Inflammatory mitral prolapse plus here is mitral stenosis also. And these are things which could be observed in patients with acute rheumatic fever. Not very rarely we see it in Kerala, but still common in many parts of Bihar, Orissa, Rajasthan, and some of the other states. This is a lady who is systemic lupus erythematosus. Essentially similar changes in all discollaginous, except some peculiarities. This particular patient had classical pericardial effusion, but at the same time, this patient also we managed medically without putting in a needle because we thought we can manage pericardial fluid by medical management itself. Here is a 35-year-old college professor who came to our hospital for cardiac failure. He had severe pulmonary hypertension. His look reminded me of one of the detective stories of Sherlock Holmes by Arthur Conan Doyle. Nose was sharp, hands were hard to touch, and that gave me the proper diagnosis. Look at the very large right ventricle, all signs of pulmonary hypertension, reverse D of the right ventricle, all features of severe pulmonary hypertension. At the same time, there is some pericardial fluid. The severe pulmonary hypertension is shown by the tricuspid velocity, and patient was in congestive heart failure. IVC was markedly distended and standing without any collapse. What is this? You're wondering, this patient with pulmonary hypertension developing pericardial effusion is considered to be an ominous sign. It's supposed to be the late stage of natural history of pulmonary hypertension. At the phase of pericardial effusion, none of your treatment will be available. So I was called in to see at this phase of the echo, and I said, this is not pulmonary hypertension alone. It is something different. Look at the pericardium. That pericardium is not normal. This patient obviously has pulmonary hypertension, but the pericardium is not normal. What is this? It is an exudative pericarditis. You may find that this pericarditis, this pericardium contains fluid with amorphous material, and pericardium is so thick and spongy pericardium, and this irregular in certain areas. So this exudative pericarditis is not a transudate. Pulmonary hypertension produces a transudate. Thicker pericardium, amorphous pericardial effusion, severe pulmonary hypertension. Look for signs of discollaginosis. This patient's face and hands indicated that it was on a progressive systemic sclerosis. That's a famous story of Arthur Conan Doyle, when the whole family thought patient is leprosy and completely kept him away. And this Sherlock Holmes went and diagnosed. Sherlock Holmes was a doctor, and diagnosed with progressive sclerosis, brought him back to the society. Localized pericardial effusion. That's also occurs. I have about 5 or 6 cases in my diary. 38-year-old farmer referred to medicine department for lots of symptoms. He had been to many hospitals, for the same symptoms, which varied from joint pains to severe myalgia and exhaustion. Investigation showed mild anemia and an ESR of 116 in the first hour. JVP was raised, but he did not give any symptom of heart failure. And when we looked at him, when we looked at the echo, we found something very, very unusual. Look at this picture. Is there anything striking you? Something was very peculiar here. You find there is very little pericardial effusion behind the left ventricle. Can you see that? Very little pericardial effusion behind the left ventricle. All the pericardial effusion is above the right ventricle. And see, it is here. Not only that, this pericardial effusion is making the RV flow tract collapse. This pericardial effusion is making the RV flow tract collapse. So this pericardial effusion has a high intrapericardial pressure, even though it is a localized pericardial, even though it's a localized pericardial effusion. You find that the RV flow tract collapse was in diastole, proving that this is an indication of localized pericardial effusion producing some sign of tamponade, and you find that tamponade is an early sign of the early sign of tamponade is diastolic collapse of the RVOT, and that's what we saw in this particular patient with localized pericardial effusion. It's very, very well known that localized pericardial effusion, even if it's localized, can produce pressure effects depending on the intrapericardial pressure. The intrapericardial pressure rises above the intrapericardial pressure, when it rises above the cardiac pressure. Here it's the RV pressure. It definitely presses on the RV flow tract, produces collapse in diastole. The pericardial effusion, as you may find, is mostly around the right ventricle, as you see here. It's a localized pericardial effusion. So a localized pericardial effusion, which is producing pressure effects on the right side of the heart. We wanted to do a myocardial study. We did a bullseye and the longitudinal strain, and we found that longitudinal strain was substantially reduced, mainly in the basal and the mid segment, mainly the basal and the mid segment. And you can see the basal segments having lost the strain, and this indicates that there is definitely a myocardial pathology. So this patient not only has a pericardial pathology, but a myocardial pathology. Localized pericardial effusion with pericardial pathology. Involved in the myocardium, as shown by strain image. Patient with mixed connective tissue disorder, localized pericardial effusion can produce signs of tamponade. So I present a series of cases with connective tissue disorders because connective tissue disorders are not very uncommon, and they present at random to the echo lab. And you should not mistake the pericardial effusion due to associated pulmonary hypertension or any other thing. It is part and parcel of the pathology of dyscollagenesis. Now move on to chronic pericarditis. Long history of intermittent chills and fever is cachexia. Often presents at the site as a dependent edema, elevated JVP, phasic pericardial rupture, often tuberculosis in origin. This is what is chronic pericarditis. A 48-year-old businessman with febrile illness for 4 weeks, paradoxical pulse, came to us, and this is what we saw in the echo. Good amount of fluid around the heart, all around the heart, and some echo densities in the pericardium, and you find the fluid is quite a bit substantial. That's why the paradoxical pulse came. I'm sorry, my slide is not moving. When we did the okay. Let us see whether it's moving. Okay. See, when you look at the pericardial cavity, you find lot of material in the pericardial cavity. The pericardium was extremely thick. The visceral pericardium was extremely thick. There's a lot of stuff close to the visceral pericardium as well as the parietal pericardium. It was so thick, you could find it's about 3 centimeters in width. So much of material collected within the pericardial cavity. And you can see the thickened pericardium here, and so much of material collected attached to the visceral pericardium as well as to the parietal pericardium. So much of muck is collected, and this is what you call as classical, one may call it as caseating pericarditis. Visceral pericardium 4.5 millimeters thick on CT. Mediastinal subcardial lymph nodes larger than 2 centimeters. The presence of the subcardial lymph node more than 1 centimeter is a sign canon, is a sign of tuberculosis. So you should look for the subcardial lymph nodes in every patient with chronic pericarditis, especially the type that you saw with plenty of material within the pericardium and appearing to be caseating. This indicates that this is a tuberculous pericarditis. It was reported some time back by Professor George in the British Heart Journal. The sentinel node in the subcardial region indicating a tuberculous pericarditis. Mostly tuberculous, less commonly myocardial infection. Chronic pericarditis starts as recurrent pericarditis. Go to chronic pericarditis. Chronic effusive constrictive. Then there is a change happening. Not only effusion, in addition, the thick pericardium which I showed you in the M mode start pressing on the heart, impairing the ventricular filling. That is chronic. Still there is some effusion, chronic effusive constrictive pericarditis. And finally, the whole area becomes calcified. As a shell, will not allow the heart to dilate or fill, ventricles to fill beyond a certain point. That is the phase of constrictive pericarditis. Look at this. This particular patient's whole pericardium is calcified. Whole pericardium is calcified. And pericardial calcification are best seen in on fluoroscopy or CT scan. Here can be beautifully seen at the end stage of long phase of pericarditis, pericardial inflammation. Long phase of pericardial inflammation is the final stage. You find the heart is a small thing, encased within a lot of caseous material filling up the pericardial cavity and not allowing the ventricles to fill. And that's the phase of chronic constrictive pericarditis. Chronic constrictive pericarditis is chronic inflammation of the pericardium. Inflammation, chronic fibrotic scarring, restricted cardiac filling, calcification, and fix of pericardial cavity. That is what happens in constriction. The pericarditis with adherent visceral and parietal pericardium, this is the phase of pericardial effusion with thickened pericardium. There is chronic effusive constrictive pericarditis and established pericardial effusion. The constrictive pericarditis may show you a peculiar sign called the septal bounce. Septum bounces and comes back. Septum bounces and comes back. Sorry. Yeah, this sign is very classical of constrictive pericarditis. This could be appreciated in 2D as well as in M mode, but could be best appreciated in M mode because as a sudden, sharp, posterior movement of the septum in early diastole. We are now dealing with the constrictive pericarditis with whole set of thickened pericardium all around. You may find this constrictive pericarditis affects many other hemodynamics of the heart. Normally, in a left heart failure, you find the E by E prime will be more than 15, it is 19.8. The E by E prime will be more than 15, it's 19.8 in left ventricular failure. It will be less than 8 in a normal individual. 8 to 15 is to be discussed in relation to other side. So here, this is the normal phenomenon. E by E prime increases as the left ventricle phase. It's an instantaneous reaction, and with one dose of Lasix, E by E prime may come back to normal. But in constrictive pericarditis, E by E prime is inversely related to pulmonary capillary or LA pressure. Transmitral flow velocity to mitral annular velocity, that is E by E prime ratio, is inversely proportional to pulmonary capillary pressure in patients with constrictive pericarditis. E by E prime will be smaller and smaller in constrictive pericarditis, in spite of elevation of LV diastolic pressure and LA pressure substantial. With increasing LA pressure, pericarditis, in normally E by E prime increases to more than 50. This is called annulus paradox. Annulus paradox. This is the classical E by E prime decrease with elevation of LA pressure. This patient an annulus paradox with E by E prime only 2.53, and this patient the pulmonary wedge pressure was 35, I think, yeah. And so also, normally, the medial annulus of the mitral valve moves with systole and diastole. With systole it goes up, diastole it comes down. Lateral annulus also does the same thing. With lateral annulus, it is so free to move up and down. It is not restrained by the cerebral fibrous body. So lateral annular movement will be much more than the medial annular movement, But in constrictive pericarditis, this is the usual thing. You find the medial mitral annular movement is much smaller when compared to the lateral annular movement. Look at this normal phenomenon. But in patients with constrictive pericarditis, the lateral annular movement is hampered. It is constrained by the thick fibrous tissue infiltrating into that region. The lateral annular movement is restricted. So this is called the reversal of annular movement. Annulus reversal. Septal E prime 17, lateral E prime 8. That's the annulus reversal. So there are so many signs, clinically also. You'll find that, it's supposed to taught you. Constrictive pericarditis is a disease of sign. Echocardiographically also, it's a disease of sign. So many of which I try to show you. Why the confusion with restriction constriction? Both result in diastolic heart failure. Myocardial diastolic heart failure, you have a stiff non-compliant ventricular myocardium. Pericardial diastolic heart failure, you have thick and non-compliant pericardium. Both affect ventricular failure. Restricted cardiomyopathy is an idiopathic or systemic myocardial disorder characterized by restrictive filling, normal or reduced LV and RV volumes, and normal or nearly normal systolic LV and RV function. What can be demonstrated? Restrictive filling pattern, stiff ventricle, normal or reduced RV and LV volume, normal or near normal LV and RV systolic function. Look here, the mitral Doppler shows early diastolic filling is very little. The deceleration stroke is so fast. Most of the filling occurs in later, mainly in atrial systole. This is the classical feature of constrictive pericarditis. There is an early diastolic filling, then the whole filling occurs in the rest of diastole with atrial contraction contributing. Look at the P wave here. Atrial contraction contributing to main part of filling of the left ventricle, and hence this patient always suddenly worsens with the development of atrial fibrillation. Early diastolic filling is impaired with the fast deceleration stop. Both pictures may look similar in a four-chamber view, normal-sized ventricles and dilated atria, pericarditis, constrictive pericarditis, and restrictive cardiomyopathy. Restrictive cardiomyopathy has definitely disorders: myocardial, infiltrative, storage diseases, endomyocardial. I will not go into the details of it. That is not the point of discussion today. But we have differential diagnosis: clinical, ECG, plain skygram, echo Doppler, CT, MRI scanning, endomyocardial fibrosis, biopsy. Endomyocardial fibrosis is the last one to do. And because if none of the other thing could differentiate between whether it's constrictive pericarditis or restrictive cardiomyopathy, you may have to go for endomyocardial fibrosis. But endomyocardial biopsy, even in the hands of the best clinician and all the investigation, sometimes the differential diagnosis becomes difficult. There are many instances where a thoracotomy was required for the final diagnosis, even in the best of centers. Restrictive cardiomyopathies do not have any signs of inflammation, while inflammatory cardiomyopathies do have signs of inflammation. Ladies and gentlemen, I presented a series of cases showing acute pericarditis, recurrent pericarditis, as in discology, chronic pericarditis, chronic effusive pericarditis, and constrictive pericarditis. The sequence of events happen. Unfortunately, constrictive pericarditis today is more often due to postcardiotomy or due to uremia rather than due to tuberculosis in most parts of the world. In Kerala also, we rarely see constrictive pericarditis due to tuberculosis. While rest of India, especially North India, I find whenever I go there, I find many patients with constrictive pericarditis. So this disease had to be kept in mind and to be diagnosed correctly. Inflammatory diseases are the diseases are amenable to treatment, either as curative or as palliation. So all investigation should be done to identify the etiology of the disease. The follow-up of these patients with echocardiography is extremely rewarding and should be documented and archived. Thank you for patient listening, all my colleagues. Thank you.
Thank you so much, sir. That was very interactive cases that you have shown to us. Dr. UP Singh, sir?
Yeah, wonderful. I think let's go to the questions because your talk was fabulous as usual, but to the point and brief.
Thank you. Thank you.
That is something your USP. All right. So, I mean, there is something very, very important. Dr. Sarkar wants to know a very good question. That is it possible to take measurement of pericardial thickness on echo? And what are the fallacies? Should we do it? Should we not do it?
See, when you are suspecting pericardial thickness increased, echocardiography, it should always be confirmed by a CT scan. Never put all your cards on echocardiographic thickness in pericardium. You can suspect a thickness, but confirmation has to be by a CT.
I think there are a lot of issues with the physics of ultrasound. The moment the ultrasound wave strike a very shiny pericardium, most of it would get reflected. And if you try to take a measurement of pericardial thickness there, chances are that you are not going to be accurate. Sir has told very rightly that CT is the technique of choice to take, and 4 millimeter, am I right, sir, should be the range for saying whether it's normal or abnormal. The cutoff of thickness of pericardium, sir?
It should be less than 4.
Yeah, correct. Okay. And then
see, the visceral pericardium is basically thin and filmy. What is the thickness? It's thin and filmy.
So Dr. Abdullah wants to know that where should we take a measurement of pericardial fluid?
See, number one, there should be evidence of tamponade. You should definitely take out the pericardial fluid. 2, Repeated aspirations and examination of fluid did not give you a diagnosis. You may have to resort to other techniques. And number three, in spite of all your techniques, without aspirating, you cannot make a diagnosis. Then you have to put in a needle. There is a Barcelona criteria to decide on a pericardiocentesis, and it strictly tells you pericardiocentesis should not be taken very lightly. If you are confident that you can treat the patient without aspiration, do it without any harm to the patient. But if you definitely want to make a final diagnosis without the pericardial fluid examination, it's not possible. Go ahead and do it.
So,
Mesothelium is one of the conditions where you need a pericardial fluid.
the question is, where should we take a measurement of pericardial fluid? I mean, how do we?
Pericardial fluid measurement is always done in the parasternal short axis view, EM mode, in diastole, in end diastole, in M mode, in the parasternal short axis view, because long axis view near the AV groove, you may find a little separation. A short axis view is a good imaging technique to measure the width of the pericardium and pericardial fluid.
I think recently there was a good paper where they tried to measure pericardial fluid like we do left ventricular mass measurement. You take an epicardial surface of the heart, and then you take the pericardial outside the pericardial fluid, and there is one of a technique which they said is more accurate.
Okay, thank you.
Then the question from Dr. Shahrukh is, what is the initial treatment of viral pericarditis with a small pericardial effusion and patient does complain of a pericardial chest pain?
See, most of the common viral pericarditis, you need only analgesics. If it doesn't settle on analgesics, you can go to NSAIDs, and NSAIDs will definitely settle it. If you still find it progressing, you may have to go to colchicine. It's a sequence of treatment. And the analgesics, go to NSAIDs, and finally to colchicine. And this is how most of us treat. And if you find, if you have still the pericardial effusion continuing in spite of colchicine, you may have to think of tuberculous pericarditis. You may have to even give a trial course of anti-tuberculous treatment or aspirate the pericardial fluid and examine the cell.
Sir, he wants to know, how do we differentiate? Could you elaborate on differentiation of pleural versus pericardial effusion?
See, the AV groove contains the aorta. AV groove contains the aorta. I can take the picture. AV groove contains the aorta, and it is identifying the aorta is what you must look for in identifying if it's a pericardial effusion or a pleural effusion. I'll come to it now. One second. That's right. This is descending thoracic aorta. This descending thoracic aorta is within the fluid, which means this is pleural effusion. If this is the descending thoracic aorta, it is outside the fluid. So this is pericardial fluid. A pericardial fluid will not enclose the descending thoracic aorta, while a pleural fluid will enclose the descending thoracic aorta. I think this picture, the video moved now. Earlier it did not move.
The next question, sir, is what are the normal values of septal E prime, lateral E prime, and E to E prime ratio?
The normal ratio is less than 8. Abnormal is more than 15. E by E prime 8 to 15 should be interpreted on other accompanying signs, clinical and echocardiographic. I normally do not give any value to it. If it is more than 15, I consider it as definitely LV failure. Because there's a lot of literature on the gray zone, 8 to 15. More than 15, we know it's abnormal.
There are two questions. I think that's a separate topic in itself. One is that diastolic flow reversal in hepatic veins. And second, similar thing is that how do we differentiate between constrictive pericarditis and effuso-constriction on echo? Would you like to answer that?
Yeah, the atrial reversal is a common echocardiographic sign when you look at the hepatic veins. This occurs as a short reversal of flow during atrial systole, immediately after the P wave. It's a normal phenomenon. This is exaggerated when the right atrial contraction is very strong, as in patients' pulmonary hypertension. I'm very happy to say that endomyocardial fibrosis, very classical again in tricuspid stenosis. These are conditions where atrial reversal is very markedly prolonged, but it's very commonly seen in patients with pulmonary hypertension, and that is the hepatic reversal of atrial systolic flow.
Now, the question is, sir, septal shudder can be seen in pericardial effusion and pericardial constriction. How to differentiate? No, Dr. Sridhar wants to know, do we get septal shudder in pericardial effusion as well as pericardial constriction?
No, only in pericardial constriction. Only in established constrictive pericarditis.
Yes.
You see the septal shudder.
We don't get it in pericardial effusion alone.
Yeah. 2D as well as in MOD.
So this question of pericardial thickness has already been answered. Dr. Inderjeet wants to know about, when would you like to do a cath in a patient of, pericardial disease? I'm putting it a little broadly, sir.
See, whenever you want to do a pericardiectomy, do a coronary angio in an elderly patient, and it's better to have a cath done and the pressure is established. So this is the mainly before a pericardiectomy that we do the cath.
So I think the question next, Dr. Vachalu's question is answered already. Quantification of pericardial fluid by echo. And I move on to the next question of role of steroids. I think I would also like to know what is the status in today for a tubercular pericarditis, and is there role in a viral pericarditis also?
Acute viral pericarditis. I'm sorry, I missed the steroids.
Mm-hmm.
The analgesics, NSAIDs, steroids, and then only colchicine. I missed the steroids there.
All right. And what about tubercular pericarditis, pericardial effusion?
The
pericarditis.
Earlier, when we were using streptomycin induces intense fibrosis. So there is a major role for tuberculosis, for steroids in tuberculous pericarditis. Now we have to sort of decide on which patient needs to have steroids or not. Routinely, we do not give steroids to tuberculous pericarditis.
Okay. So then Dr. Sabina wants to know what is the importance of RA collapse in pericardial effusion?
It's a very specific sign, very good sign. The right atrial collapse is a good sign for pericardial effusion. See, when the, I don't know, I don't know whether I have a picture here. This is the right atrial collapse. Can you see the right atrial collapse? This is the right atrial collapse. The right atrial collapse occurs when the intrapericardial pressure rises above the intracardiac pressure. When the intrapericardial pressure goes above about 8 centimeters of water, you find that the right atrium collapses. When does it collapse? Right atrium can collapse only when the right atrial pressure is the lowest. When is right atrial pressure the lowest? When the right atrium relaxes. When does it relax? It relaxes in ventricular system. So this is when the ventricle contracts. When the ventricle contracts, you find the right atrium collapses into it, or inversion of the right atrium happens, and you can see very easily the right atrial collapse in this particular video.
Yeah, I think that's a very good point. And moreover, I'll just add a small point that, I mean, it's a differential pressure between RA and pericardium. There are situations where RA pressure is low in dehydration and stuff like that. You might get an RA collapse earlier. And, there are conditions when RA pressure is high, like sir has showed a case of severe PAH. And in those situations, the RA collapse probably would happen quite late. So there is a question, I think people still want to know about septal bounce. They want, if you could explain it again, septal bounce.
The abrupt posterior movement of the interventricular septum in early diastole that happens in constrictive pericarditis. This is a pressure reversal that happens. It requires a little longer explanation. That's why I did not go into the details of it. Yeah, that's right. An abrupt pressure reversal, pressure reversal at the beginning of systole is what happens as the septal bounce, and that produces, it goes towards the left ventricle and then back. It goes towards the left ventricle and then back towards the right ventricle. That's why you get a shudder-like phenomenon, especially when you look at the 2D, and this occurs at the beginning of diastole. That's the beginning of diastole.
Dr. Prashant Rana wants to clarify. He's written, sir, books have mentioned for lateral E to E prime more than 13 and septal E to E prime more than 15 as elevated filling pressures. But that's in diastology, not in constricting. Yes, sir, your comment, sir.
See, I showed two pictures. This I said it's a normal phenomenon. It's a normal phenomenon. And where the E by E prime has gone high due to left ventricular failure. And here you find, here you find the E by E decrease with elevation. And then we go to the usual and normal phenomenon in an individual will be septal tissue Doppler will be smaller than the lateral tissue Doppler, because lateral one can move freely. This did not happen in constrictive pericarditis. And you find that in constrictive pericarditis, what happens is the medial movement will be more, lateral movement is less, and that's called annulus reversal. This is because of the restrictive movement of the fibrocaseous and calcified pericardium acting on the annulus.
Dr. Sanjeevni wants to know about what is the square root sign that we use in cath lab.
I showed you the square root sign. I'll get it again. Square root sign is a phenomenon that was described earlier, the cath lab tracings. The cath lab tracings in patients with pericardial effusion, as well as in LVEMF, you find a classical square root sign that there is a, because the elevated LV and diastolic pressures, when the mitral valve opens, the 1 second. The mitral valve opens. Suddenly, the whole the LA pressure is high. Suddenly, the whole blood can come into the LV. But this flow is immediately impeded by lack of distensibility of the left ventricle. So the deceleration slope will be very fast. Then it is arrest. Rest of the filling can occur only in the rest of diastole, and that's why atrial systole is so crucial and so important in these patients. And that's a very important hemodynamic phenomenon in patients with constrictive pericarditis. I think I have a picture here.
I think we need to. I think it's there have been plenty of compliments on your very elaborative and very simplified talk, and this is an area which we generally don't try to understand too well, but you explained it so nicely and things are very clear. I think we call it a day, and
I thank every one of them
for
for the kind words.
talk, sir.